Thank you, Jennifer. Thank you, LIGHTMED, for the invitation. It's really special to be here talking with a global audience about something that I trust and something that I've been studying for a while. My name is Carlos Eduardo. I am from Brazil, and I'm just talk a little bit about myself. So I study medicine in a south city of Brazil called Florianopolis from 2004 to 2010. And then I got into the ophthalmology residence till 2014. And then I moved to São Paulo to do my retina, uveitis, and ocular fellowship from 2014 to 2017. Currently, I am the head of uveitis and a PhD candidate in São Paulo Federal University. And I'm also ophthalmologist specialist in São Paulo Eyes Hospital. Nowadays, my research topics are the vitreous laser treatment that we're gonna discuss today, as well as different doses of intravitreal steroids and uveitic macular edema. So let's move on. And my first topic will be the vitreous, our object of study. And vitreous is not more than a soup of water. So water corresponds for 99% of the vitreous body. But there are also this special element, the collagen, and here the specific types 2, 9, and the type 511, which has this name because there are fibers from both types. It's really special when you talk about the vitreous opacity. So there are also non-collagenous glycoproteins and glycosaminoglycans and proteoglycans. Regarding the anatomic division, we can divide the vitreous into central, cortical vitreous, and the vitreous base. And here's something important that I want to point out. So when you talk about the treatable vitreous opacity, the most of them resides in the central vitreous. So we should avoid those opacity in the cortical vitreous due to the proximity of the retina. And I'm just going to talk about that a little bit later. And when you talk about the vitreous opacity, the first thing that should come out in our mind is about the collagen aggregation. So, and here I'm talking especially from the aging process. So the primary vitreous opacity, and at the top we can see those bundles. The thick gray lines form the type 2 collagen. They are interconnected, but by the type 9 collagen. So with the aging process, is a loss of the type 9 collagen, and then those type 2 collagen bundles had aggregation, and then the vitreous opacity are formed. And what are floaters? So floaters are the light scattering on those opacity formed by different shapes, size, position within the vitreous cavity, leading to different subject perception of the opacity. And there are several causes of floaters. The most important is the aging process one, but we also have uveitis, hemorrhage, surgery, and even medication causing floaters. And what about the prevalence of the floaters? Actually, there isn't any global study about the prevalence of floaters, but according to the American Academy of Ophthalmology, the prevalence has been reported to be as higher as 1/4 among patients age 60. And according to the NIH, over 300 million people suffer from this disturbance. So we know that it's really frequent, especially when we reach the middle age, and it's really frequent in our routine as ophthalmologists. But is there anything we can do about it? And then we keep listening those statements like, there's nothing we can do about it, or our patient's gonna learn how to live with it. But yeah, for those small, asymptomatic, and peripheral opacity, the observation remains a good option of conduct. And on the other hand, we have the vitrectomy for those diffuse and dense, especially those secondary vitreous opacity. And so the vitrectomy could be a good weapon for those patients. But between those two groups, we have a huge percentage of patients, and then the YAG laser, it's come out as a good option of the treatment, and it's what we're gonna talk from now. So just let's talk a little bit about laser, about physics. The the laser is the shot of light amplification by stimulate emission of radiation, and any kind of laser have these three elements: a energy source, a active medium, and an optical resonator. Specifically for the YAG laser, the diode is the most common energy source. The active media is the energy YAG crystal, and there are mirrors to build up the light energy in the beam. And the use of YAG laser in vitreous floaters has been discussed since 1986. And then we ask ourselves why it has bring up again as an option of treatment of the vitreous opacity. And here I want to point out two specific things that has improved in technology. The first one is the illumination, and the second one is about the energy delivery. So about the illumination, there are those former lasers from 80s and 90s with a non-coaxial illumination, and the new lasers with a coaxial illumination, which means the illumination, the AMI beam, and the laser delivery are in the same pathway, which provides a better visualization of the posterior vitreous, the main vitreous and the posterior vitreous. So which allows a better visualization of the structures, the vitreous opacity, and the surrounding tissue. And about the energy delivery, the new lasers has efficient dispersion of energy even at the high levels required for posterior YAG procedures. And specifically for the LIGHTMED, I always like to emphasize those two aspects. The first one is about the fine focus AMI beam system, which allows both beams to converge together, so we can clearly see, and this is really important, we can clearly see the spot over the opacity, so we are clearly see what we are doing. And the second one is about the crystal key switch laser technology, which provides a better tissue cutting precision with a lower energy levels, which provides a reducing treatment side effects. So with this state-of-art technology, our procedure nowadays are safety with better precision and effectiveness. And this is really important to understand. So here I brought animation. It's animation from vitreous detachment. That is where it comes from the most treatable patients with the formation of the rise rings floater over the posterior pole. And then we can clearly see the end beam over the spot of the opacity. There we go. And then start the vaporization. Here is our first report published in the International Journal of Retina and Vitreous. It was a study with 32 patients and complaining of floaters with a good results that I'm going to show later in the presentation. So what about the qualifying patients? It's a frequent question, and for me, it's the most important part of this presentation. Who are the best candidates for the YAG procedure? And I always ask myself those 5 questions before any procedure of laser. And the first one, and the most important, is the patient's perception. So to have the presence of the opacity cannot be the only reason to YAG laser procedure. So we need to make sure that our patients are complaining about the floaters. We need to make sure that the floaters really bothers our patients. The first question is about the amount. So the most treatable opacity are those small opacities, not those diffuse secondary opacity. The third question is about the type. So as I said, the primary floaters, those small primaries, central floaters are the most treatable ones. The fourth question is about the location that I've mentioned before. So central vitreous should be our mainly treatable opacities. We should avoid the cortical vitreous and those opacities within the 2 millimeters of the retina and 2 millimeters of the lens. And the last question is about the eye condition. So we need to make sure that we have a clear cornea with no cataract, so we can clearly see all the opacity and the surrounding tissue. So who are our best candidate for the YAG procedure? A patient with a small primary central vitreous opacity complaining of a limitation in a daily basis activity. And what about the treatment protocol? And this is something really important, especially for those that are starting out the procedure. And here I split into pre-treatment, treatment, and post-treatment protocol. So I always discuss anticipated treatment outcomes and risk with the patients, and then I will show a case of mine that will exemplify the importance of this statement. Ensure patients complete sign as consent form as I do for any procedure in my patient's eye. I undertake a full eye examination and with attention at the retina and periphery just to see if there is any break around the periphery. So I strongly recommend a minimum size of pupil of 6 millimeters. I perform a OCT and retinal photography for all my patients just to check a current condition and rule out any retinal macular pathology. And those are the two devices that I always use to perform the vitreolysis. The first one here in the left is the Vitreous is a lens made specifically for the vitreous, so it improves our visualization of the vitreous body. And the second one is the LIGHTMED laser that we're gonna talk a little bit further. About the energy of the LIGHTMED laser, it ranges from 1 millejoules up to 15 millejoules, but most treatment can be performed at approximately 5 millejoules per shot. It's very important to know that you really need to titrate the power up rather than starting at higher energy levels. So I always start with 1 millijoules. More energy, of course, will be required if the vitreous opacity is located deep in the posterior vitreous. The number of shots will vary depending on the type of the vitreous opacity and on the amount of the vitreous opacity, but it ranges from 200 to 600 shots per session. And I strongly recommend you to only use 1 pulse per shot because it's safe and we have a better energy delivery in this situation. In the presence of multiple vitreous opacity, I always start from anterior opacity, then I proceed to the posterior ones. You can move the eye up and down or left and right throughout the procedure. So it may move the vitreous opacity to a safer position. And I'm gonna talk about safer position later. It's important always to obtain a clear view of the vitreous opacity as well as the surrounding structures. So it's really important to have a good visualization with a good device. And how do we know, and this is a frequent question made by residents and other colleagues, how do we know where the floater is in relation to the lens and the retina? How do I know this 2 millimeters of security? So clinically, if I see the floater in the same focus and the retina in out of focus, we know that we are safe to fire. So if the retina and the floater are in the same focus or near the same focus, I never do the laser. And I always try to move the eye up and down so the floater can move to a safer position. But if I'm not able to do that, I don't perform the laser. And if the floater is anterior positioned, we can place the slit lamp in the off-X position, I mean in the oblique position, and I will show an image of that, which provides a more contrast of the floaters, allowing better visualization of the posterior capsule. And throughout the procedure, I continually assess the position of the floaters using both on and off axis to ensure a constant feedback in spatial context. And then I'm gonna show you now. So here is I am doing the procedure. Here in the left, you can see an on-axis mode that is better for the posterior opacity, so in the mild and the posterior vitreous, and the off-axis is better for the anterior opacity. Here is an image exemplifying that. So the left is the on-axis, so they are better to see opacities in the posterior vitreous, and on the right is the off-axis. They are better to do procedures in the anterior vitreous, as well capsulotomies. So my post-treatment protocol, I generally don't use any medication. They are not necessary. There are no restriction of patient's activity at all. I always recommend a patient's follow-up at the next day and 1 week after the procedure, so I can check the IOP and the visual acuity. And I strongly recommend to see these patients in a dilated exam within 4 and 6 weeks to assess outcomes as well as retinal evaluation. And what about the side effect? And this is a really important part of this presentation, because we need to be aware and we need to know how to avoid those complications. So the most dreaded complication, it is the retinal hit and the traumatic cataract. So as I said, we should avoid those peripheral opacities and those within 2 millimeters of the retina and 2 millimeters of the lens. But here is important note, especially for those starting out. Always consider observing a wider margin of those measures of safety, and treat only in the central third of the vitreous, and always avoid the direction of the macula if you are a beginner. So this is a really important thing. And this describes increased intraocular pressure. I've been studying this. I've been performing YAG laser since 2018. I have performed over than 500 procedures, and I've never experienced something like that. But it's described to be more liked in older patients with compromised trabecular meshwork drainage. It's more likely in treatment of dense vitreous opacity and those anterior vitreous. So it's in these patients is recommend limiting the number of shots to 400 shots per session. So let's talk about my experience. And I'm gonna show you some case of mine with the parameters. So the first case is a 56-year-old male complaining about visual disturbance for 2 years with a limiting near distance activity. The best correct visual acuity was 20/20 in both eyes. The intraocular pressure in the right eye is 14, in the left eye 16, with no signs of uveitis and retinal disease. So here we can clearly see this opacity, this visor ring and over the posterior pole. And then I use the LIGHTLas YAG laser from LIGHTMED and the mild vitreous, and the spot size of 8 micras and a power titration from 1. I always start from 1 millicholas, but I went up to 5 millicholas, which was enough to vaporize the entire opacification, the entire opacity, with 322 shots. And here we can clearly see that the entire opacity was vaporized. So here in the left is before the procedure, and in the right, after the procedure. The second case is a 63-year-old female. She complained about visual disturbance for 5 years with a limiting outside activities. Best correct visual acuity of 20/20 in both eyes, intraocular pressure of 10 and 11, with no signs of uveitis or retinal disease. So here we can clearly see those opacities in the retina, on the vitreous actually, those small opacities. And here I use a power titration. I started with 1 millicholas, and I use both 4 millicholas and then 5 millicholas to treat these patients with 346 shots. And here we can clearly see that the entire opacity was gone, and the left is before the opacity and on the right is after the opacity. So you can see that we can definitely treat those patients with a small symptomatics opacity and with 300 and 400 shots with a low energy levels of 5 millijoules. And here is the third case, the third and last case. It's about a 56-year-old female complaining about visual disturbance for 3 years, a best correct visual acuity of 20/20 in both eyes, a intraocular pressure from of 10 in the right eye and 11 in the left eye, with no signs of uveitis or retinal disease. And here we can clearly see this opacity over the optic disc. And then I perform the YAG laser with a power of 4 and 5 millijoules, and I performed 253 shots. And here's something really important to know, and I want to point out here. We're not always able to treat the entire opacity of our patients. So when I was doing this laser, the opacity goes further to the retina and the optic disc, so I was not able to perform the laser, even moving the eye up and down and left and right. So then I stopped the procedure, and then I explained to the patient. And that's why it's really important to discuss anticipated outcomes with your patients. We cannot guarantee the entire vaporization of the opacity. So this is really important to know. So in conclusion, I definitely 100% sure that the LIGHTLas YAG laser can be safe and effective in the treatment of vitreous opacity. And as important as the technique is to know the best candidate for the procedures, especially those 5 questions. And the first one that says about the patient's perception of the opacity. Always discuss anticipated treatment outcomes and risk with your patient. Some vitreous strains or opacity can be easily and effectively treated as a show, but some vitreous cannot be treated as a show in the third case. And sometimes more than one treatment session may be necessary to achieve a satisfactory result. Thank you so much. It will be a pleasure to answer your questions.
Okay, thank you, Dr. Souza. That was really informative and very detailed. Thank you very much again. We do have a few questions here, so I'll start by reading some of them off, and then you can provide your best answer and go back to your presentation as needed. So I did have this question also yesterday, and I know you did a really good job as well, just giving us your protocol and your recommendations. I do have some people that have been very nervous, I guess, to bring this to their practice for the first time. So, I mean, how would you promote the treatment to your patients? For example, for somebody who's new to bringing this to their practice, can you give us some advice, because you've been doing this for so many years, you know, especially in the beginning? What would you say to the doctor and to your patients? What kind of advice?
Yeah, the most important thing is to choose the best candidates of this entire this huge world of floaters. We need to choose the right ones to hit the laser. So as I said, consider do the laser only in those in central third of the vitreous, and avoid peripheral opacities, avoid those opacities that are dense and diffuse in the vitreous cavity. So try to do laser only on a safer position, and try always to titrate the power. Start with 1 millijoules and then 2 millijoules, and going up till 5-6 millijoules. That I'm sure that's really enough to vaporize the opacity. I know that in the beginning it's really can be scary to this laser, but trust me, you can do very well if you choose your best candidate, your best patient.
Okay, perfect. So as you mentioned, you have to titrate. For those that are new, start from 1 millijoules to up to 5 maximum. So how many, I mean, you said about like, in your cases, you presented 300 on average, about a little bit over. Is there a maximum amount of shots until you tell, you recommend the doctor to maybe stop and recommend a second session?
Yeah, actually, the 5 millijoules is where most of the treatable opacities are done, but we can use like up to 8 millijoules. I already did like with 8 and 9 millijoules, so 5 is not the maximum, but the most opacity goes very well with 5 millijoules. And about the range of shots, I always can vaporize the entire opacity, ranging from 200 to 600 shots. But for those elderly patients over 70 years old, it's better to limitate the shots till 400, because every shot you use, we have energy delivery, which can be harder for your retina. So keep in mind that 400 will be a good number for older patients.
Okay. Perfect. And also, how many sessions do you recommend if you can't get rid of all of them in one session? Can you do a second? Can you do a third?
Yeah, we can do how actually there's any number of session that is studied, but if you see that your opacity is still in a safe position that you can hit it again, I mean, you can do any how many sessions do you want? So if you want to use like 4 sections or 5 sections, it doesn't matter. The only thing that you can have in mind is that the opacity should be in a safe position, because sometimes when you're treating, the opacity just go forward the retina, so you need to stop, and then we can't do it anymore.
Okay. Perfect. And those of you that are not familiar with our YAG laser, now that you're on this slide, Dr. Souza, I just want to point out that all of the spot sizes are set at 8 microns, and they don't, you can't change them. So this is also just another safety measure for those of you that are doing this for your first time. That is not something that you need to set on the YAG, but that is true that it is 8 microns. Okay, so how long does one session usually take?
Yeah, the spot size is the standard of YAG.
How long does one session usually take?
It's about 20-30 minutes.
30 minutes, okay. Let's see, let me see what other questions we have. Okay, yeah, another question was about the same thing. It's about how many sessions does it usually take to completely vaporize? So like you mentioned, right, it's dependent on the patient and the position.
Normally, yeah.
Mhm.
Yeah, normally I can do the entire opacity in one session. Like 80% of my patients go just with one session.
Oh, wow.
For those small opacities, I mean, this one and this one, just one session is enough with 340 shots. You can definitely do it with just one session.
Oh, that's great to know. I know you mentioned this during your presentation already, but I think it's a good question to repeat one more time. So how do you estimate the distance of the opacities, like 2 millimeters from the lens or less, 3 millimeters from the retina?
Yeah, this is a really good question, and it's really a frequent question. So actually, I can't measure this 2 millimeters when I'm doing the procedure, but clinically, what I do is if the floater is on focus and the retina is out of focus, we are safe to fire the laser. But if they are in the same focus, or if they are closely in the same focus, I don't perform the laser. So it's basically like that. But you will clearly see if the opacity are in the third in the mind visuals. I mean, in the beginning, it's going to be clear to you if the opacity will be in the mind visuals. So if it's further from near the retina or near the lens, you should avoid it.
Okay. You did mention that you were able to treat some floaters in the anterior segment of the eye. So I do have a question for, can you treat it without using the mid-vitreous lens or the accessory lens?
Sorry, I didn't get it.
Okay, so during your treatments, you mentioned that you use the mid-vitreous lens, right? The question I have from someone here is, can you treat an anterior floater without using the lens?
With the same?
Mm-hmm.
No. I always use the lens. I not recommend you. It provides a better visualization of the vitreous with the lens.
Okay, perfect. Also, does the floater break into smaller particles, or do you actually make it disappear completely?
In the beginning, when we start the procedure, it will break into small pieces, but then after that, we will vaporize the entire opacity. So when you're starting out the procedure, it will break into small pieces, and then you go further, and then you start to vaporize these small pieces.
Okay. Are there any other lenses that you can use for this procedure, or only the mid-vitreous?
Yeah, I always, since I began this procedure in 2018, I always use this one. But yeah, there's several types of lenses in the market that you can use that are made specifically for the vitreous.
Okay, does the use of NSAID help in post-op?
Using what? Sorry?
NSAID, N-S-A-I-D.
Yeah, I don't use that.
Okay. Let me see. Okay. Some vitreous laser lenses have different focal depth. I know you have that one that you recommend. Do you know the focal depth of the mid-vitreous lens that you currently use, and can it cover most cases?
You're talking about the magnification?
Just the focal depth. So I know, from my understanding, I know that like the one that you have on your presentation is from Volk. I know the Oculus had several different ones with different focal depth. So do you know the focal depth of yours? And if not, I think it'll probably be online.
Yeah, I'm not sure.
Okay, but this is the only one that you used and you recommend
Yeah.
it. Very successful.
I strongly recommend this one. So this one is, you can clearly see the spot over. I've tried like two to three different types, but this one is, for me, is the best one.
Okay. I'm going to try a question in Spanish.
You can say in Spanish, maybe I can.
Yeah, I'll read it to you and then let me know if you understand it. And if not, maybe Benicio, you can translate it to English for me. But al final podemos preguntar en español dos preguntas claves. ¿Cuáles son los pacientes los cuales no califican para este procedimiento?
Okay. Who are the patients that don't qualify for this procedure? Maybe it is.
I believe that is.
Yeah. So I think that the question that should be made is, which one is your best candidate. So you have to avoid those patients with cataract or corneal opacity. You should avoid those patients with diffuse large opacity because the laser don't go well on those cases. You should avoid patients with peripheral opacities or those opacities close to retina or the lens. And but the most important is to make sure that your patient is complaining about the opacity. So you should avoid those patients with asymptomatic vitreous opacity and focus on those that have a limiting activity in their daily basis life.
Okay. I don't know, is it possible for you to answer the question in Spanish too, or not?
I can try.
Whatever you're comfortable.
Yeah, I just have to change my set mind. Maybe if I speak in Portuguese, they will get
Yes,
better.
I think so. Yeah.
Na verdade, eu acho que o mais importante é a gente entender qual que seria o nosso melhor paciente. Então, aquele paciente com uma opacidade central, pequena, que realmente esteja incomodando ele. Então, ter a opacidade vítrea não pode ser a nossa principal indicação. Precisa ter a opacidade vítrea, a opacidade vítrea, o paciente reclamar, isso ser uma coisa incômoda para ele, e também avaliar a localidade dessa opacidade. Então, evitar aquelas opacidades periféricas ou muito próximas da retina ou muito próximas do cristalino. Mas eu acho que, para quem está começando, aquelas opacidades centrais no vítreo, começando com uma energia baixa, de 1 milijoule até 5 milijoules, eu acho que tem uma segurança fantástica hoje com o aparelho LIGHTMED pela qualidade da iluminação e da eficiência da energia. I think I answered that.
Perfect.
I don't know if it was enough for them.
I think it's great. We can have people translate after the presentation to their colleagues. So, and if anything, I will let you know if it's something was not clear after the presentation.
Okay.
Email. Thank you.
You're welcome.
You did mention that after your treatment, you have a 1 week post-op or post follow-up. And if, for example, you have or you recommend another session to get rid of the rest of the floater, it's in a safe position, how many days do you wait in between each session? That's like a safe measure.
Yeah, I always wait like 30 days apart.
30 days?
30 days, yeah.
Okay.
So I performed I follow up in the next day and the next week, and then I wait like 4 weeks, and then I perform a dilated exam just to make sure that everything is all right with the retina, and then I perform the laser again.
Okay. Let's kind of shift over to like when you said, when we were talking about promoting it to your patients, and this is a new thing, how do you like, how do your patients react about this treatment when you talk to them about it? Is this painful or are they happy? Can you talk a little bit about the patient experience?
Yeah, sure. Yeah, actually, it doesn't. They never complain about pain, so it's a really comfortable procedure. And with it takes like 20-30 minutes, as I said, and the patients, it's really nice because like the day after the procedure, the patient is already happy, and he came to the office like in a very happy mood because it takes off like something that was bothered him in years. So it's really nice to see the patient's reaction just the day after the procedure. It's really nice.
Also, like, for example, in your case presentation, case C, or your third one, and you said you couldn't get rid of all the floaters. Is this a case that you would possibly retreat in the future?
Yeah, just if I make sure that the opacity moved to anterior position, a safe position, because if it's not, I will not perform the procedure. So that's why I have to stop the laser, because the opacity moves toward the retina, and then if it doesn't move for a safer position after weeks and month after that, I would not procedure the laser again.
Okay. Sorry, there's other like questions, kind of different topics here, but is the multifocal IOL a limiting factor?
Sorry?
Is a
No,
multifocal
not a limit.
IOL?
No, not at all. You can do
No.
it. No, not at all. Like the same tension that you have with the lens to not hit the lens, we will have with the multifocal IOL. So it's not you don't need to avoid those patients.
Okay.
An important thing to say about the C case is that even this patient improve his symptomatic floaters after the procedure. So that's a really good thing, because even if you don't vaporize the entire opacity, you can give to the patients a better life, a better improvement in symptoms.
That's really amazing. We love it. What about, and you don't need to answer this, but what do you usually charge per session to your patients, especially in like a private practice? Or do you have like a range that you know?
Yeah, actually, I charge in reais. So for the Brazilian audience, it will make sense, but it's about 1,000 reais. That would be like $200 per session.
Per session.
Per session.
And then, is there, and do you know, I know you only use one lens, but do you know if there's an off-axis lens that you can use for floaters that are not completely central?
Off-axis lens. Actually, the off-axis is from the slit lens. So I've never heard about the off-axis lens. So that would be interesting, because the off-axis improves your visualization in the anterior vitreous. But what you can do is use the same lens and then move throughout the procedure the axis in the slit lens. So you can use the on axis and off axis during your procedure.
Okay. That's perfect. Looks like all of the questions so far have been answered. I'm going to allow another few minutes if anybody has some last minute questions. And yeah, I think that will be it. We'll end the session as soon as we just are finished with the questions here. Oh, okay. Here's another good question. Do you suggest or do any combination when you do vitreolysis with like YAG capsulotomy as well?
Yeah, it's a good question. I've been performing this like for a while, and it's a good combination. You don't need to worry about anything. But if I proceed to the YAG capsulotomy, I always give steroids after the procedure. So just to make sure that you're not gonna have any uveitis secondary to the procedures. But yeah, you can definitely do both in the same time.
Okay, that's great. So overall, I think it definitely seems like a relatively safe procedure and something that can really change a patient's quality of life. They're happy with the results. You're happy with the results. it's nice to see that you've done so many cases. So you've shared your experience of, you know, the very successful cases versus those that may not be qualified, and given us a very good overview of the risks, which are very, very important to consider. And again, repeating what you'd said before about those that are doing there for their first time, making sure that they start with a lower energy and they gain the confidence, I believe, right, over time. And now that you can treat a higher energy 4 to 5 at the best, with the best results, and about 400 maximum shots. So I think overall, I think all of the questions have been answered very well, and we will end the session. I just want to ask you maybe to say last few words about the laser itself and your experience in working with the laser, and then we'll end the session.
Yeah. First, I want to thank you the opportunity. I think it's really nice and really special talking about vitreolysis, because it's something that has bring up again in our routine, and I think I really trust in this procedure, and especially for those that are beginning, that are starting with this activity, try to remain, try to treat just those opacity in a safe position, to be a really 100% confident of what you're doing. And I'm definitely sure that it's a safety procedure and a really, really effective procedure to our patients. We know how frequent the floaters are in the worldwide population. And as I said, over 300 million people suffer from this disturbance. And nowadays we have something to do with these patients. We have something as to treat these patients with the YAG laser. Thank you so much, Jennifer and LIGHTMED.
Yes, thank you, Dr. Souza, for sharing your wonderful experience and giving us the confidence to also bring this to more practices around the world, and being able to treat the patients and giving them, again, the better quality of life. So we really appreciate your time today, and hope everybody has a wonderful weekend, and we'll see you next time. Thank you.
Thank you.